therapeutics which are used to alleviate the problem of asthma. So that in itself is quite an exciting area. In the 20 so years I've worked in the asthma field, there's been quite a marked improvement with respect to the therapeutics which are available to treat asthma. So let me try and get my slides up. So here we go. Let's see if this works. Just green. This one. Share.
Here we go.
All right, we get in there.
Fantastic.
Okay, so as I just mentioned, today's topic is asthma, its pathology and treatment. Let's see if I can. So first, let's describe asthma. So it's like asthma has been known for quite a long time, at least 150 years. It was initially described, and asthma as a term originates from the Greek meaning shortness of breath. Now, the first person to describe asthma as a disease condition was Henry Hyde Salter, who worked at the Charing Cross Hospital in London. So he described asthma in about the mid-1800s. And he wrote quite an important book describing asthma, its symptoms and its treatment. So on asthma and its treatment is one of the first books written on the subject. Salter was an expert in the field. He noticed in the early days that asthmatics, if they drank coffee, the coffee actually alleviated some of the symptoms, and it turns out to be the caffeine in the coffee which alleviates the symptoms. And it was Salter who made that initial observations. Now, asthma is a big problem. So it's like the recent estimates are, so the first page of a grant, if you're writing a grant to work in the asthma field, is over 300 million people on the planet suffer from asthma. And asthma is a big problem in the USA. There's anywhere between 5 to 8% of the US population which suffers from asthma. And some of the numbers actually state in excess of 10% of people in the US suffer from asthma. And approximately 2 million people every year turn up at the emergency ward because of an exacerbation of asthma. Now, typically asthma can be treated, so there's relatively few people who die from death of asthma every year. And it's like typically the ones that do die are because of clinical maltreatment. The important thing to take on board about asthma is that its prevalence has really been increasing in the Western world over time. So the statistics are there's an increase in prevalence by about 50% every decade. So the graph shown here is actually for children over the years, and you can see this progressive increase in asthma prevalence, and nobody really understands why that is. You know, it's like these data go back to the 1980s, but nobody's really come up with a good idea as to what's driving this increased incidence of asthma. There's talk about the hygiene hypothesis, which has been around since the mid-1986, but nobody's really kind of proven, you know, what it is that's driving the increased incidence of asthma. Now, asthma, people who suffer from asthma have the whole spectrum of severity, but anywhere from 5 to 10% of asthma sufferers progress until they reach a point where they have severe disease. And severe disease is problematic because many of the therapies that are used for the treatment of asthma really don't impact as effectively in severe disease. So there's a lot of importance when when researching this subject as to come up with solutions to treat people with severe asthma. Now, you probably heard about the incidence of asthma and how it's associated with the Western world. This came from Nature some time ago, probably a good decade ago, and it's like it's essentially drawing the incidence of asthma around the planet, and it kind of falls out like you would think. So it's like the highly developed countries in North America have a high incidence of asthma. These statistics are actually put in the US at 10.99%. Like I say, these numbers do vary a lot depending on your source of material. And if you look at Asia, for instance, Asia's got relatively low incidence of asthma. So again, this is a basic understanding that asthma is associated with the Western world. It's less evident in India. When you go to Australia and New Zealand, you have a high incidence. Brazil for some reason, has a high incidence. And the UK, where I come from, has a high incidence. Unfortunately for the Scots, the highest incidence on the planet is in Scotland, which is kind of unfortunate, because not only does it rain all the time, you're also more susceptible to developing asthma in that part of the world. So there's a geographic distribution of asthma. And again, nobody really has a good idea as to what underpins that distribution. So let's have a look at, yes?
Sorry, I was wondering, so is that just based on reported cases, or is it based on like the same diagnosis criteria? Because wouldn't each country maybe have a different diagnosis criteria?
I think it is on reported cases. So it's like, yeah, there might be a slight difference. I mean, that might explain why the numbers are higher than what's typically reported for the US. Like I say, the US is normally somewhere between 5 and 8%, but they're stating 10%. So, but yeah, the diagnosis of these things is problematic. And yeah, it's got better over the years. There's more standardization, but that might explain some of the drift in the numbers. Okay, looking at asthma in terms of the symptoms which are part of the disease. Well, as you're probably aware, in asthma, you got airway constriction. You can demonstrate inflammation of the airway. So it's like if you look at really just the large and the small airways along the cuboidal epithelium of the airway wall, you can see an infiltration of inflammatory cells. In most cases, say 75% of cases of asthma, those cells include eosinophils, and associated with the inflammation, you've got production of excessive amounts of mucus. So you got these goblet cells in the airway wall, which are secreting mucus, which contributes to blocking the airways. Towards the severe end of the spectrum of the disease, you can get a shedding of the airway epithelium, and that's what results in asthma death. Normally what happens in asthma death is that you shed airway epithelial cells, they become associated with a mucus. It forms what's known as a creolar body, which is just a group of cells clogged with mucus, and that blocks an airway, and that can cause asthma death. So essentially that's the spectrum. You start off by increased irritability of the airways, increased mucus, epithelial shedding when you're in the severe spectrum, and then you have to be careful. So episodes of exacerbation of asthma can be triggered by a variety of events. So you've got environmental agents that could be something like allergen. So it's like most of asthma is associated with atopy, i.e. a sensitivity to a known allergen. So approximately 80 to 90% of asthmatics are atopic. And the allergen, if inhaled, can precipitate an asthmatic attack. But not always. Cold air, exercise, exertion, or stress, that's psychological stress, can also precipitate an exacerbation of asthma. Now, certainly in the United Kingdom, the kids that turn up at the clinic in the emergency ward in the winter due to exacerbation of asthma are typically because they're suffering from a viral illness as well. So that's typically the rhinovirus, i.e. the common cold, or in some instances it can be other respiratory viruses as well. So the airway narrowing causes symptoms such as wheezing, shortness of breath, tightness of the chest, and coughing. And the inflammation, as I mentioned a minute ago, is present in all the ways, in all the airways extending from the trachea, so the large airway, to the terminal bronchioles, but doesn't extend into the alveolar spaces. It's typically just associated with the airways. So how do you diagnose asthma? It's typically by spirometry. So it's like the forced expiratory volume, FEV1, is what the primary readout to diagnose asthma, and that's essentially a way to measure the expiratory volume that can be blown out in one second. And so, as you might expect, essentially that's just a measure of airway function. So it's like looking for airway obstructions. And that's being depicted here. So you got the FEV versus time. So a normal individual can quite effectively exhale air from their lungs. In asthma, you're less effective at getting air through the airways because they're partially constricted. And bronchodilators, the beta-2 agonists, are an important therapy. So that's just showing here. It's like if you take an atopic asthmatic and treat them with a bronchodilator, you can actually improve their airway function. The sister of the FEV1 region is the peak expiratory volume, which is a measure of how hard patient can actually exhale her air. So it's like that's being depicted here on the right. And as you might expect, normal folk who have perfectly normal airways can expire air at quite a high rate, where in asthma that's been compromised. And so you normally have both of these readings as the initial diagnosis as to whether asthma is present or not. But you normally utilize additional backup tests to confirm the diagnosis, and those backup tests include methylcholine challenge. So methylcholine is
what's going on?
Sorry? Methylcholine is an irritant to the airway, and so it essentially stresses the airway and begins to move these curves down. So the normal individuals being less responsive to methylcholine, only the asthmatics are super sensitive to methylcholine challenge, and that would effectively—
You sign in via your email and your Google login.
worsen their asthma phenotype. You can also challenge the individual—
The password, it should be written on your board.
Allergen. Is there a problem?
Andrea, your mic isn't muted.
Okay, so if like I say, most of asthma is associated with atopy. So if you know the particular allergen that the person is sensitive to, you can provide an allergen challenge. And again, that would diminish the FEV1. You can measure nitric oxide, i.e. NO, being released by the individual's lungs. So it's like NO is an indicator of the inflammation that's taking place in the airway. You can take x-rays, and you can also take sputum samples from asthmatics. And that's one way to get at the inflammatory cells that are invading the airways. So it's like sputum from atopic asthmatic, it's undergoing an exacerbation, is likely to have eosinophils. So like I said, there's a whole wide range of intensity of asthma, and that's been classified by a variety of people. So it's like typically you start off as mild, intermittent. Those are mild symptoms, just once or twice a week, and possibly a couple of nights. Asthma can be particularly problematic at night because we'll talk about the late response, and that's normally when the late response develops. You can move from mild intermittent to persistent, and there you got an increase in incidence of loss of airway function. Moderate persistent, it's like if you have symptoms once a day and more than one night a week. And severe, it's like essentially folks can suffer symptoms throughout the day, most of the days of the week, and frequently at night. And these people find themselves on more severe therapies to really try and push back that inflammatory response and open the airways. Okay, so that's all well and good. So it's like, what's known about the underlying mechanisms that are driving this loss of airway function? Well, as I mentioned, most of asthma is associated with atopy. So 70 to 75% of asthmatics are clearly atopic. They're highly sensitive to a number of allergens, be it house dust mite or grass pollen. And so it's like the immune response to allergens is typically driven by T cells, CD4 cells, which have this Th2 phenotype, which you've probably encountered previously. The only thing to bear in mind about the Th2 phenotype for a CD4 cell is that those cells produce predominantly IL-4, 5, 13, IL-7. And those are the cytokines which are going to favor the development of an allergic response and drive up the IgE. So we talked about asthma, shortness of breath, bronchial hyperreactivity, such as to methacholine. And in asthma, you can, if you lab out the airways, you can see a preponderance of these Th2 cytokines. So you can see the IL-4, 5, and 13. You can actually wash them out of the airway if you lab out the lungs, or you can take sputum samples and detect IL-4, 5, and 13. So you've got this underlying Th2 response, primarily driven by CD4 cells, which people believe to be the primary event on which all the subsequent pathology is built onto. Now, it's like one of the consequences of a Th2 response is the development of eosinophilic inflammation. And the reason for that is Th2 cells produce IL-5, and IL-5 is a very effective cytokine at driving eosinophilic inflammation. IL-5 will drive eosinophils out of the bone marrow into the bloodstream, and it also facilitates the recruitment to the airways. So the IL-5 piece of the puzzle fits perfectly with the infiltration of eosinophils into the airway, which is a major characteristic of most asthma. As I said, most asthmatics are atopic, so they have heightened levels of IgE. And it's well known at this point that the cytokines IL-4 and 13 are important in driving B-cell isotype switching to produce IgE. So it's like, again, a perfect fit between the involvement of these CD4 cells making these cytokines and a raised IgE level. As I said early on, that you've got excessive airway mucus production in the lungs in asthma, and there's good evidence coming from the mouse models, but now in the human, that the cytokine, most notably IL-13, but also 9, again from the Th2 cells, can drive the secretion of mucus by those goblet cells in the airway. And towards the severe end of the spectrum, it's like you've got remodeling of the mucosa, thickening of the wall of the airway, and bronchial epithelial shedding. And this is what that looks like. So it's like here, it's a schematic. Well, this is actually normal histology. So it's like you've got a normal airway, you've got the epithelial cells here. They tend to get a little concertina during the processing of the tissue, but you can see that you've got a contiguous epithelial layer. In the case of asthma, it's like that contiguous epithelial layer is being compromised. You've got deposition of mucus, this gray material here, and you can quite noticeably see a thickening of the basement membrane and the muscle around the airway. So that's shown schematically here. So it's like here you've got the asthmatic airway, you've got an increased number of goblet cells secreting mucus. And the noticeable and really characteristic feature of asthma is that you get collagen deposition around the airways. This is the airway epithelial cells. This orange layer is depicting the deposition of collagen. So the onset of fibrosis. But unlike emphysema and other fibrotic diseases that develop in the lung, what's quite pronounced and different about asthma, it's not just simple deposition of collagen. You have a thickening of the muscle layer. So around the airway, you have a ring of muscle, and the thickness of that muscle increases quite profoundly during asthma progression. So it's like, and that's why this is known as remodeling in asthma. So it's like when you talk about asthma, it's a remodeling of the airway, not just simple fibrosis. As to the cells which are driving these kind of effects, at this point in time, there's a focus on the role of the T cells and an innate cell known as an innate lymphoid cell. So let's just quickly look at these cells in a little bit more detail. So the the T cells in asthma produce this Th2 phenotype. They produce cytokines 4, 5, and 13. And the T cells are incredibly important in atopic asthma because it's these cytokines and associated interaction with these T cells, which drives isotype switching of the B cells to produce IgE. And IgE is important because it's going to be secreted by those B cells, enter the bloodstream in the plasma, and combine to high affinity IgE receptors on mast cells, basophils, most notably. Some people will say it also bind eosinophils, but most notably mast cells and basophils. Now, for the longest time, people thought that the source of those Th2 cytokines was really only the CD4 cells. But in the past 4 or 5 years, it's become clear that there's another lymphocyte present in the airways, which can also produce those Th2 cytokines known as innate lymphoid cells or ILC2s. And the way that these cells function is that they're stimulated by the epithelium. So this is a schematic. This is a conventional T cell. So you've got allergens coming into the airway, being picked up by dendritic cells, presenting antigen to the T cells, which differentiates from this resting phenotype into this Th2 phenotype that's going to make IL-5, 13, IL-9, and essentially drive this inflammatory process. So you can see on this arm here, you got the T cells making IL-4 and 13 to activate the B cells, to produce IgE that's going to bind to the mast cells and basophils, so that when additional allergen comes through the airway, they're going to release mediators and cause a bronchoconstriction. Now, what I've just introduced is the innate lymphoid cells. The innate lymphoid cells are interesting because they work a little different, because essentially what the innate lymphoid cells are sensitive to are a series of cytokines or alarmins produced by the epithelium. So the airway epithelium sits here, and when it's damaged by pollutants, microbes, or other agents, it's like those epithelial cells produce these IL-33, 25, and TSLP, i.e. alarmins, which activate those ILC2s, and those ILC2s then produce IL-13 and IL-5. So the ILC2s add to the Th2 phenotype, it's supposed they release IL-5 and 13, but rather than being driven by dendritic cells, they're driven by damage of the airway epithelium, activating the ILC2, and the ILC2s are already pre-armed to produce IL-5 and 13. And all I want to walk away from this slide understanding is that essentially you've got the T cells and the ILC2s, which are contributing to the Th2 phenotype. that's driving the asthmatic response. Another piece of the puzzle is that when an atopic asthmatic individual inhales allergen, it essentially undergoes two phases of response. So it's like the individual will have initially an early reaction, but then a delayed late reaction. And the underlying cellular mechanisms that drive those two responses are quite functionally distinct. So we talked about the production of IgE, binding of IgE to high affinity IgE receptors on mast cells. So it's like folks who have been who are atopic and have inhaled the allergen. It's like the allergen's going to pass through the airway wall. It's going to interact with the mast cells, the IgE, cross-link the mast cells, and the mast cells will release a whole range of pro-inflammatory mediators, histamine, tryptase in the human, and a series of leukotrienes. And that's what causes what's known as the early reaction, because it happens quite quickly. So the allergen passes through the airway, activates the mast cells, and the mast cells immediate release of mediators, giving you an airway constriction. You can see a rapid fall in the FEV1 values. And then that slowly recovers. But what happens subsequently is that the allergen is left in the airway. It's been picked up by dendritic cells, which then present it to the T cells. That's a process that takes time. They have to take up the protein antigen, break it down, and present it in the context of class 2 to the CD4 cells. And so what typically happens 4 to 6 hours later is you get this late reaction. And the late reaction is because now the CD4 cells are being activated by those dendritic cells. And this is the kind of reaction that typically happens when the asthma sufferer has gone to bed. And it's this intensity of the late reaction is typically more pronounced than the early reaction. So just bear in mind that when allergen enters the airway, you get effectively two responses. You get the early one driven by mast cells, and you get this later one where you get an infiltration of eosinophils because the T cells are being activated. And it's the CD4 cells that drive this late reaction. Just want to quickly make a couple of points as to factors which contribute to the incidence of asthma. It's like there's a number of genetic factors that contribute to asthma incidence. So it's like there's a hereditary component to the development of asthma. And over the years, people have identified a whole series of genes which seem to map quite closely to asthma incidence. In many instances, the genes which have fallen out from these studies have been pretty obvious. So it's like IL-4, for instance, is a pivotal cytokine for allergic responses, as we began to discuss. Same for IgE, class 2 for presentation. The T cell receptor is involved. And we'll talk about the beta-2 adrenergic receptor. It's like, and essentially, well, I think the take-home conclusion when looking at the genetics of asthma is that there's really in excess of 70 genes which have been implicated or mapped to the asthma incidence. And so the end point is one that if it's affected by genetics, it's a very complicated genetic picture, because there's evidence for lots of genes that can exacerbate or increase the incidence of asthma. In asthma, you've also got to think about environmental factors. So it's like you're probably aware, there's a linkage between the incidence of asthma and the environment. And there's several good demonstrations of this. One is East and West Germany, when it was split into two after the war. There was increased incidence of asthma and atopy in Western Germany because it was more westernized and more developed when compared with Eastern Germany, which was more rural. And following unification of the East and the West, it's like that there was a dramatic change in the incidence of asthma. They essentially equaled out. Another instance where people point to environmental factors, and I think it's actually a good demonstration of the contribution of the environment is an instance of individuals from this coral island, coral atoll in the South Pacific. It's like was actually destroyed by a hurricane. You might expect that when you look here at the island. It's like barely above the level of the sea. And so when being hit by a hurricane in 1966, the indigenous people were moved to New Zealand, which I guess was the closest country. I think they were essentially New Zealand citizens. And it's like initially on the island, the asthma incidence was quite low. The terms was 11% of 706 children. But when those kids were relocated to New Zealand, which has a high incidence of asthma, the kids had a pronounced increase in the rate of asthma incidence. It's like reaching a point of 25.3% of the relocated kids in New Zealand. So just changing the environment can increase the incidence of asthma. So let's have a look at the therapies which are used to manage this.
Dr. Roberts?
Yes?
I was wondering if that works in reverse. If you take somebody out of a high level environment with mild asthma and put them into a low level environment, does their symptoms go down increasingly?
I think there is some evidence of that. I think that German study was actually, quite lengthy, and it looked at various instances where people relocated after the unification, and there was some evidence that people went from the west to the east. It's like it improved. So it's like I think the evidence is pretty good that the environment can impact. What's more problematic is to identify what it is in the environment that's causing this drift. I mean, some people point to it. The exposure to the allergen might be the underlying cause. That's it's like there's more allergens in the West, but that needs to be resolved. But yeah, as I understand it, it works both ways. Okay, so let's have a look at what can be done. Like I said, this is kind of an exciting area, so I got to get all this in. So it's like, because been a lot of development. So it's like the long-term asthma medications include inhaled corticosteroids. So corticosteroids are really important for the treatment of asthma. And the important thing about asthma treatment with corticosteroids is that corticosteroids can be administered to the lung. So you don't need systemic administration of corticosteroids to suppress the inflammation. Leukotriene inhibitors. So as I mentioned, you've got mast cells and eosinophils as major cells which are being recruited to the airway and which are driving the inflammatory process. Turns out those cells are highly effective at converting arachidonic acid to leukotrienes. And leukotrienes impact the recruitment and the inflammatory process and the constriction of the airway. So there's a lot of interest in leukotriene inhibitors in treating the disease. Beta-2 agonists directly increase the caliber of the airways, and it's like there's increased use of combination inhalers that use beta-2 agonists in conjunction with a corticosteroid. So the beta-2 agonists, as we see, don't really impact the inflammatory process too much, but they do increase the caliber of the airway. It's the corticosteroid which is going to suppress the inflammation. So a combination of both has been shown to be, show some synergy and is a popular way to treat asthma. Then you got theophylline, which is a phosphodiesterase inhibitor, which causes bronchodilation. And you've got mast cell stabilizers. These are all drugs, chromoglycate and necrodromil, have been around a long time, but essentially they stabilize basophils and mast cells so that the cells don't release all those mediators such as leukotrienes. So those are the long-term treatments that have lasting effects in the airway. You've also got the rescue medications. These are the beta-2 agonists are going to hit on the receptors in the airway and cause a vasodilation. You've got the anticholinergic agents, Atrovent and Spirivira. And you've also got oral and intravenous corticosteroids. This is towards the severe spectrum. And the third intervention that can be taken is to do something about the allergy component in the asthma sufferer. So you can deliver tolerance to specific allergens by giving folk allergen shots. And the exciting thing in recent years is the development of the biologics to directly impact the asthmatic inflammation. The most notable one is the anti-IgE treatment. So an antibody to IgE essentially inhibits the IgE component of the inflammation. And in recent years, there are anti-cytokine treatments to specifically target the cytokines which are driving the response, such as IL-5, 13, and 4. Okay, so let's run through these as best we can. So we got corticosteroids, been around a long time, since originally described in the 1950s. Like I said, the important thing for asthma is that they can be used as an inhaled drug, which was first described in the 1970s. And really, inhaled corticosteroids are the first line of therapy for asthma. So it's like when you're writing your grant for asthma, you've got to try and convince the reviewers that whatever you're going to develop is going to be more effective than inhalation of corticosteroids. Well, having said that, you've got to bear in mind that the inhalation of corticosteroids is only suppressing the inflammation. It's not curing the patient. Nothing that's out there really impacts the incidence of asthma. You're just suppressing the inflammatory process. So here's a schematic of corticosteroid action. You're probably well aware of this. So it's like corticosteroids have a variety of anti-inflammatory effects. They target those CD4 cells, so they suppress the inflammation. One of the most responsive cytokines to corticosteroids is interleukin-2, which drives the expansion of CD4 cells. So you see a depression of Th1. It's in an increase of Th2 differentiation, but that's kind of misleading. It's like the corticosteroids will suppress the development of Th2 cells. It's less effective on the effector cells. And the corticosteroids also impact the innate response, again, suppressing innate response and the adaptive immune response. So it's like it's shown here. They have a variety of actions, and the recent advance in therapy is to, in addition to using the corticosteroid, is to couple it to an active beta-2 adrenergic receptor. The second therapeutic approach used in asthma quite commonly, the leukotriene inhibitors. So there's two ways to inhibit the leukotriene function. So as mentioned, leukotrienes are going to be released by those mast cells and basophils. They're going to constrict the airway, and to counteract the leukotrienes, you can either block their receptor. So it's like, so leukotriene inhibitors will bind to the receptor, blocking the ability of the inflammatory leukotrienes to bind to that receptor. Or alternatively, you can use an inhibitor that blocks the synthesis of leukotrienes. And both approaches are used in the treatment of asthma. So two leukotriene receptor blockers, for instance, include montelukast, which is a popular treatment in asthma, that binds to the LTD4 receptor and blocks binding of the inflammatory leukotriene. Another LTD4 receptor inhibitor is acylate, and it's like, and both are used in treatment of asthma. Conversely, you can also treat these folks with xylitol to inhibit the production of leukotrienes. And the rationale is shown here schematically. So it's like you've got these inflammatory cells in the airways in asthma that take arachidonic acid, so that's being produced by phospholipase A2. And you've got these cells express the 5-lipoxygenase that's going to convert arachidonic acid to cysteinyl leukotrienes. These are the active bronchial constrictor agents. And it's like you have a block, the synthesis of these cysteinyl leukotrienes by agents such as xylitol that blocks the 5-lipoxygenase, or alternatively, you use antagonists to the cysteinyl leukotriene 1 receptor that binds each of these, and those agents are known as montelukast or pranulicast, safralinocast, I've not actually heard of. But essentially, there's two regimes to try and suppress the effect of leukotrienes. Then you come to the immediate agents that increase bronchial, induce bronchial dilation. These are the beta-2 adrenergic agonists. It's like they essentially function by binding to the receptor, which causes a airway a relaxation of the airway, a smooth muscle. The problem with these agents over the years is that they do have deleterious side effects, not so much in recent history, but it's like in their earliest introduction, certainly in New Zealand, the wide use of beta-2 agonists at high concentrations really resulted in a number of deaths in asthmatics, going back to the 60s and 70s. So you got to be quite careful about the dose and the frequency of using beta-2 agonists. The function of the beta-2 agonist is to bind to the adrenergic receptor, activate the G protein to produce cyclic AMP, and the cyclic AMP activates protein kinase A, resulting in a calcium flux, which drives the bronchodilation. To assist in that, it's like you can also inhibit the phosphodiesterase. So it's like cyclic AMP is going to cause a bronchodilation, and within the smooth muscle of the wall, there are phosphodiesterases, most notably phosphodiesterase 4, that's essentially going to convert that cyclic AMP to AMP. And so by blocking the action of phosphodiesterase 4 by the methylxanthines also provides a way to cause a bronchodilation. So you got the beta-2 agonist binding to the adrenergic receptor causing a bronchodilation, and you can achieve a similar effect by inhibiting the phosphodiesterase 4, which would essentially degrade the cyclic AMP. Just a quick word about beta-adrenergic receptors. They exist in long or short-acting form. And the difference between these two compounds is that the long-acting forms have essentially been made hydrophobic. So they put in a long alkyl chain in the long-acting beta-2 agonist. And that assists in these analogs to associate with the membrane of the smooth muscle cells, and that serves to increase the length of their action. Second thing that's been utilized in the use of these beta-2 agonists is to couple them with known corticosteroids. So it's like Advair uses the corticosteroid fluticasone in addition to salmeterol. Salmeterol is a long-acting beta-2 agonist used in conjunction with a corticosteroid, and similarly from Symbicort. Okay, let's move on. So theophylline is another way to treat airway constriction. So theophylline essentially inhibits phosphodiesterase. So it's like it was early described by Salter, as I mentioned in the 1880s, that caffeine is effectively causing a bronchodilation. And it turns out that it's a weak phosphodiesterase activity. Theophylline and methylxanthine are also found in tea, when these agents are more long-acting and cause a reduction in the bronchoconstriction. So that's being illustrated here. So here they're varying the concentration of caffeine and theophylline treatment of the airways, and they see the inhibition of the airway constriction. And then we come to the more recent approaches to impact asthma. So it's like the two novel therapies which are available for the treatment of asthma are to neutralize the IgE. As I mentioned, the IgE acts on the basophils and the mast cells in the airway. And an additional approach that's been recently developed is specifically targeting those Th2 cytokines. For first, the IgE. So IgE is present in the blood serum, but it's actually present at very low levels, somewhere in the order of 300 nanograms per mil, compared with 5 mg per mil for IgG. And one of the reasons that IgE has such a low level in blood serum is that its receptor, the high affinity IgE receptor expressed by those mast cells and basophils, has a very high affinity. So most of the IgE that enters into the bloodstream binds to the high affinity IgE receptor and essentially sits on the surface of mast cells and basophils. So most of the IgE is not free floating in the serum. It's actually bound to the surface of those responding basophils and mast cells to trigger the inflammatory response. It turns out that anti-IgE therapy is highly effective in treating asthma. And so the anti-IgE monoclonal antibody that's most frequently used is omalizumab, which is Xolair, and it was introduced in 2002, and over the years have been shown to be used quite safely in adults and children. And the way that Xolair operates is that the anti-IgE sequesters the IgE present in the serum, and it actually binds to a region of the IgE molecule that would associate with a high affinity IgE receptor. And so it blocks binding of IgE to the IgE receptor on the basophils and the mast cells. And really by blocking basophil and mast cell function, it's been proven to be highly effective at reducing the frequency and severity of asthma. And it's like typically the omalizumab is delivered as a bolus of 150 or 350 milligrams of antibody every 2 to 4 weeks. And as I said, it's well tolerated in adults and children. And then most recently, like I said, monoclonal antibody therapy has been directed to specific cytokines which underpin that Th2 response. Today, the most effective one has been an antibody to the IL-5 receptor. That's benralizumab, or known as Fasenra, which is that's highly effective because the antibody to the IL-5 receptor not only blocks binding of IL-5 to its receptor, the antibody binds to the surface of the cells because the receptor is expressed at the level of the plasma membrane, and that directs killer cells to kill cells which are responsive to IL-5, which is most notably the eosinophilia. So in the asthma phenotype, where it's like the inflammation shows a lot of eosinophils, the anti-5 receptor therapy, Fasenra, shows a high promise for improving the condition in those patients. Similarly, anti-IL-5 therapy directed to the cytokine itself is shown to have some therapeutic effects, although it didn't really impact airway hyperreactivity. It did reduce the number of eosinophils, and similarly by targeting the Th2 cytokine IL-4 at the level of the receptor, you can reduce the exacerbations. The disappointing one over the years has been anti-IL-13 therapy. So it is so 13 is part of the Th2 response, but antibodies that neutralize IL-13 in asthma patients has yet failed to cause any therapeutic effects. And there are other antibody therapies which are being introduced which target those alarmins. So here's a schematic essentially showing you which cytokines are being targeted by recent therapies, essentially targeting different arms of the Th2 response. And the last 2 points I want to make is the 2 remaining agents which are typically used for the treatment of asthma as well are analogs of atropine. So it's like this is Atrovent, and these analogs essentially serve to cause a bronchodilation. And the last agent that is, like I mentioned at the beginning, chromoglycate and necrotamil are essentially old compounds, been around a long time. They serve as mast cell stabilizers and so inhibit the release of mediators by mast cells present in the airways. And so to try and pull that all together, it's like when treating atopic asthma, you have a number of options available to you. In mild asthma, the typically introduction of the short-acting beta-2 agonist is sufficient to remove most of the symptoms. As the severity of asthma increases, then there's a change with respect to the therapies which are used. So it's like if you got persistent asthma and require daily medication, you typically inhaled corticosteroid is required. And that can be also substantiated by treating with chromoglycate, leukotriene antagonist, or theophylline. If, as you drift towards the severe asthma part of the spectrum, as I mentioned, in severe asthma, those individuals are refractory to some medicines, and it's like here, you can need high-dose corticosteroids, you need the introduction of beta-2 agonists, and maybe even anti-IgE therapy if there's a known allergy. And failing that, you might have to consider the administration of oral corticosteroids in addition to the introduction of corticosteroids in the lung. Okay, I think that's a good place for me to finish. Sorry, I had to rush towards the end. I got to lose some of these slides, but hopefully you got a broad appreciation for asthma, the nature of the disease, and the therapies which are available to treat the disease process.
Kevin, thank you for an absolute terrific presentation. Thank you very much.
Well, a little rush towards the end, but yeah.
Very good.
So hopefully the slides are self-explanatory. I try to put all the information on the slide, so.
It's there.
Okay, it's there if you look for it. Okay, guys.
Thank
Thank
you.
you.
Thank you.
Thank you.
Keith, really quick, can I ask you a question?
Sure.
Sorry, Kevin. This is more class regarding the class. In terms of the correct answers for the exam, are you going to release those, or do you usually? I don't know what your policy is on that.
Usually do, yeah.
Okay. So, do you want me to post a key to Moodle?
That would be terrific if you wouldn't mind doing that.
Okay. Yeah, that's not a problem at all.
Appreciate it very much. Thank you.
Yep.
We'll see you tomorrow.
Bye now.
Bye, Kevin. Thank you.